Hi, and welcome to the MedTech Insider, where we give you an inside look into all things med device. I'll be your host today. My name is Parker Snedden, and I have a distinguished guest here with me, all the way from Southeast Georgia, Dr. Chris Bovinet. Dr. Bovinet, it is awesome to have you here in Kansas City. Thanks for joining us.
Yeah, absolutely. Thanks for having me. Excited to do this. It's actually my first ever podcast.
You were just telling me that before we started, and I got to tell you, it's a privilege for us to have you on. And I know you've been on lots of discussion boards and panels, and I've seen you on the internet and on video everywhere, right?
Yeah.
But the first podcast, that's amazing.
I usually try and hide my voice and hide my face from the camera, but yeah, real insider look here. We'll see.
Yeah. Okay, so I think most of our audience is going to know who Dr. Chris Bovinet is, but give those an inside look who may not know who you are. You're practicing in Georgia, and how long have you been in the space?
So as you said, my name is Chris Bovinet. I'm an invasive spine physician. I practice in coastal Georgia. I got offices in Brunswick and St. Mary's, Kingsland area, Georgia. Been practicing for 12 years after I completed my spine and pain fellowship at the Medical College of Virginia. And I'm the current president of Georgia Society of Interventional Pain Physicians down there in Georgia, and loving life.
Yeah, that's great. Yeah. You said coastal Georgia, so there is a coast in Georgia?
There is. Yeah, we have about 90 miles of coastland, but interestingly enough, we have 2/3 of the East Coast marshland is in Georgia. So on the small little island the size of Manhattan, about 4 miles wide, 12 miles long, they say we have over 2,000 miles of trails, but most of them are on water. So lots of kayaking and whatnot there.
Yeah. Do you spend a lot of time on the water?
I enjoy looking at it, and fishing and going to the beach. But yeah, it's a good time. Lots of fun there.
Yeah, that's great. Well, I want to give our audience like an inside look into who you are, Dr. Bovinet. And so I want to ask you, what got you interested in pain in the first place, and why do you love it?
Wow. So roundabout way of getting there. I've always wanted to be a doctor since I was 8 years old, but I wanted to do pediatrics. But when I got to medical school, I had a first year kind of mentor going over physical exam classes, things like that, and teaching us different things. And he tried to get me into going to the pain space. He's like, do anesthesia, we'll pay you $500,000, do all this. But he's like, it's 90% boring, 10% panic. I'm like, no thanks. And as far as the peds thing, he talked me out of it because he's like, do you want to see your kids or everybody else's? And at the time, I had no kids. But I'm like, all right. So I decided I wanted to do sports medicine. You know, ortho I thought was the best route to get there. So I did ortho. I spent about 10 months doing that, which helped me in my current career as far as understanding biomechanics and joint preparations for fusions and really getting into looking at images, and I focused a lot on that. But what really got me into pain was after doing a couple 39-hour shifts in ortho, like going in at 4 a.m. on a Tuesday, not being done till 7 p.m. on a Wednesday because we were on call and going all night. I'm like, you could keep your money. I want my family time. And so somebody said, check out PM&R. I'm like, what the heck is that? They're like, well, plenty of money and relaxation. So you could still do the spine, you could do these procedures, you could do all this stuff without having the crazy call hours. So I'm like, all right. So I checked it out the month of the match and like, all right, we got to get out of this. So after doing like 10 months of ortho, I get into PM&R and I go into that, go to Medical College of Virginia and still thinking I want to do sports, right? So I got to MCV that had a very well-run program, great exposure to spinal cord injury, brain injury, sports medicine, and spine, which I didn't really know they did. But my very first rotation there was at the spine clinic, the spine center. And we do lots of cool stuff, which back in the day was a little more limited than where we're at now. A lot of cool stuff has happened in the last decade. But we're doing spinal cord stimulators, pain pumps, doing peripheral nerve stimulators, like bat wing goggles on people, super infraorbital nerve, peripheral nerve stimulators. So some cool stuff for the pain space back then. And I was watching a Duke at Michigan State basketball game at 9 o'clock on a Tuesday night. And I would have loved to be at that game. Loved to be there. I'm sure you would too.
Yeah, Duke at
Maybe not your
State.
team, but good game, right? 2 blue bloods. But I didn't want to have to be at that game. And that's what I was thinking about, that pain, sports is happening nights and weekends. And I didn't want to miss out on family time. And I was like, I was really enjoying the spine stuff. And it was really cool to get to use my hands, like the ortho piece of it, but doing all these smaller procedures that have great value and great benefit to procedure and get them out of pain. You know, a lot of people deal with pain, think, how do you do that all the time? Just giving them pain pills? Like, no, there was so much more. And we were spoiled there where we had somebody doing all the pain pills. We were just, you know, he would go see them, set them up for injections or physical therapy. He'd say, all right, go see the boys. You know, there were some girls too there, but initially it was just the boys there. But we were the guys doing the procedures, doing different things, and it was cool. So we had so much high volume. We got to see a wide breadth of all the stuff, but then seeing the impact that it did in the patients. You know, seeing them afterwards in follow-up. Luckily, there was no PAs or NPs. It was just us residents, or fellows. So we got to see all the follow-ups too and say, hey, they're doing great, and seeing the benefit we had. And like I said, seeing the explosion of new procedures in the last decade, it's been a really fun time to be an interventional spine physician.
Yeah. I love that. I want to take you back to your first comment here. You said you were 8 years old and you said you wanted to be a doctor. What sparked that? That's pretty young to be like, I want to be a doctor. That's cool.
I don't know. I guess it was so early on. I guess in elementary school, I got put in this talented and gifted program. It's called the TAG program. There was, one kid from each school. I think there might have been two from my class, me and my Hari Kumar, to call him out. Doing great, big things, Hari. He's a vascular surgeon now, doing some cool things. But they pulled us out, and we got pulled out to do other things and more advanced things. And it's like, all right, just trying to think, all right, what can you do outside the box and doing something bigger? And I thought, hey, the best thing out there, let's be a doctor. It wasn't a rocket science. I want to be a doctor. But I already loved little kids. I had a little brother and a little sister, and I loved hanging out with them. And it's like, all right, just want to nurture them and be a good person, take care of them. Like, all right, be a doctor, take care of kids. So that was it.
Yeah, I love that.
That was initial
started
draw.
really early on for you.
Yeah,
it's
8 years
carried
old,
you
yeah.
to where you are today. Has your why? So it sounds like for me, like as I'm listening to you explain your story here, like you love to see the outcomes of the patient.
Yeah.
Right. It's different than palliative care, especially in the PM&R track and what you're doing now. Has your why evolved over time as you've extended your career on?
It's still that basic mantra of wanting to help people, like when I was 8 years old, but seeing the ability, what we could do and how we could improve them functionally. So getting into the PM&R route is all about the functional thing, improving their function. So these people that had a stroke or a spinal cord injury, brain injury, and they couldn't even dress themselves or take care of themselves. Those basic low-level things that most people take for granted, that's a big deal for some people, getting back to that. Or then people say, hey, I can't walk to my mailbox, without it hurting. I got to take a break when I get there. These little things, it's like, these are the simple things that we should be able to get patients back to, So being able to get them back to that is what kind of drives me and drives me to look at new procedures and see what the functional outcomes are. So it's fun seeing that. And the sad part is sometimes I don't see that. My PAs see that, but luckily I read all their notes, But it's seeing that, or people come back and be a hug, or when they bring their family members to me or their loved ones, they show up, oh, I did great because you did that thing for me 3 years ago. Like I went to a nursing home a couple weeks ago, and this guy I saw 5 years earlier just did an ablation, a simple ablation. He's 95 years old. He's telling all his friends, oh, Dr. Bovinet's here. He's like, you did that procedure on me. I'm still doing great. Look at this. 95, no walker, no cane, doing wonderful things, But he came in and saw me for a different part of his body, and it's that keeps you going for sure.
That's super gratifying, I'm sure.
Absolutely.
Yeah. We had the privilege of coming down a year or two ago doing some patient testimonials down at your spot and interviewing some of your patients. And it's just fun to see the outcomes and how they're doing, isn't it? It's so great.
It's so rewarding. I mean, some of the patients we've had a patient said she's dragging her foot as she walks in there. Then she hikes Yosemite with her daughter on her bucket list. Couldn't lift her foot up, and now she's hiking. That was fun. I had a sweet little 91-year-old lady that lived alone that we put a Minuteman in. She said she hadn't cleaned her cupboards in 6 years because she couldn't reach up. She was so flex forward all the time, but she could finally reach and clean them. I'm like, all right, can you come clean mine too? They're kind of dirty, Do you do windows?
Yeah.
Thanks, that'd be great. So it's been wonderful to see the things we could do with these devices.
I love that. And one of the reasons I wanted to have you on the podcast is I follow you on social media, and you are really good at even you mentioned this at the beginning, like I chose this track because I wanted to do other things with my life too, not just work, right? Weekends, nights, like you wanted to spend time with your family. You do a really good job of just balancing the demanding life of a pain physician with being able to do things you enjoy too. So how do you do that?
Well, maybe not well, but I try to. So the way I picture it, we kind of have four burners in life. One burner is family. Another burner is work. Another is fitness and health, and the other is social and friends. You can't have all four burners going full max burn because you'll burn up all the gas. You're going to burn out really quickly. So I kind of, when I'm at work, I want to be hardcore at work, focus on that, get rid of distractions, not being on social media, not trying to talk to the reps too much, not worried about this, that, the other. Obviously, take care of families if you need to, whatever, but focus on the work. But then when you leave work, let's turn that burner down, like not let that burn you out. Okay, so what was easy for me living on the island, what I would drive home, and I'm driving east, and I look in my rearview mirror, and I see the sunset behind me. I'm like, all right, going out, here's an island, here's the water, let all your cares go away. Just forget all the bad that happened. Now let's focus on your family, focus on the next thing. For my health and fitness, I try and do it first thing in the morning. So get up 3 hours before I have to work, get anything I need to be done, then go to the gym, get it done. So you get a checkbox for the day. Your check mark's already done. You've done more before 7 a.m. than most people do all day. So, all right, we've got that done. And then it's like, all right, we try and have the friends, try and have a little golf in there, have the basketball, whatever, but not too much of that. So moderation on alcohol, if you're going to do that, moderation on time away from family. But it's like you can't have all four burners going at once, but focus this, that, and the other, know when to do it. And I try and balance it that way.
Yeah. I'm sure that some weeks you're great at that, and some weeks it's more of a challenge, but that's such a good way of looking at it. I'm gonna steal that from you, by the way, because I don't know if you're like me, but it tends to be a little muddied some days where it's like, oh, had that challenge at work, but I'm still thinking about it tonight, right? So it's a good way of balancing it. I like that.
When I was working before medical school, I did a corporate IT network services job for a Fortune 500 company, and I remember distinctly on a cubicle wall, there's a little picture, and on it, it just said, life is 10% what happens to you and 90% how you respond to it. Mm-hmm. So it's all about, how you can't control the situation, but you can control how you respond. You can control your emotions and how you react to things. It's the one thing we have in our control. So not let things get to you that much. If things really stress you out, well, good. Go get that good workout in. Let out your frustrations so you don't take it out on your family or your friends or the workplace. So, I try and that's what helps me balance things.
Yeah, that's good. Okay, let's bring it back to your work, part of your life. So as we think about just the interventional pain space today, where do you see it going in the future? What are some of the challenges? Where is the space evolving?
Well, it's evolved a lot in my 12 years of practice here. I look around in my office and I have all these posters and pictures on the wall. None of these things were around when I was in fellowship when I finished in 2014. It's been cool that, like you said earlier, that we used to just palliate things. Now we're actually fixing things. We're fixing, biomechanically dysfunction and improving the patient's function and their gait, things like that. So that's been awesome. It started with interspinous distraction devices, spacers that, and interesting enough, it was the failures of those is why I found spinal simplicity in the Minuteman procedure. I had to take out some of those failed interspinous spacers to put in a Minuteman, and great outcomes, by the way. Mm-hmm. But I tell people I love spinal cord stimulators, one of my favorite things, but they're high-tech Band-Aids that cover up. It's like if you take your car to the mechanic and it just squeaks and rattles and the guy's looking through things, can't find anything wrong. What do? I was like, well, you turn up the radio just to cover it up, So that's what the spinal cord stimulators do. And sometimes they can feel like they're fixed and it's cool. But, when that interspinous spacer came out, it wasn't awesome at what it did, but it was a first early step for us. The piled procedure, the mild, being able to decompress and do something. The Minuteman going in there and opening up these patient spines that have these narrowed canals, instead of them walking over all the time, self-decompressing, well, we could do that for you. I said, instead of you leaning forward, leaning on the shopping cart, it's almost like putting the shopping cart in there, holding it open, that way you could stand upright and it won't close down on itself. So it'll keep it there and keep your bones from slipping if you have that instability. So that's what's been fun in seeing the evolution thus far. What I like the idea of is improving facet fusions. Some of these patients, I did one the other day on a 64-pound lady. 64 pounds, at 4'11".
64 pounds?
When I first started seeing her, she was 78, just gradually kind of got down. So obviously has osteoporosis. Yeah. And she was told she would need a fusion, but they said there's no way they were going to do that because the bones were too thin, which makes sense. And I couldn't do a Minuteman because spinous process is too thin. Yeah. But the beauty of facet joints is that arthritis, they get sclerotic. They're hardened, so I could do something intra-articular facet. So we did that for her, and she's doing great. But I like to see improvement in the facet fusion space to open up these patients that already had like a laminectomy, for example, or they have adjacent segment disease. They don't have a spinous process at the level below or above, so we can't do a traditional Minuteman. I tell my patients, I'd love to do this device, and I'll show them a picture of it. It's kind of like we're jacking up a car from the ground to the frame, But when you don't have the ground below it or there's no frame there, you can't do that. But if you still have the facet joints there and there's no pars defect, there's something we could do there if you could still self-decompress. Yes, that's where I like it when they've already had a laminectomy, which decompresses central canal, but they still have a lot of recessed stenosis or neuroforaminal stenosis, and they self-decompress. Putting something in there to lift it up, I think, would be a game changer for us. I said a few years ago at Aspen talking about doing a 360 fusion where we go transforaminal through Camet's triangle, getting into the disc space, lifting that up and coming in posteriorly. Then 6 months later, Flare Hawk comes out.
Yeah.
But I'm like, all right, well, I'll stop saying my ideas on stage, but maybe keep them to myself or work with an R&D department that could, that's much smarter than me, that could build these things I might conceptualize, and that might be fun in the future.
Yeah. Now, where do you think the space is headed then? Like, what are you excited about?
Well, it's been more graying and graying of the lines over the years. We know some people talk about turf wars as spine physicians, spine surgeons, but it's, there's so many patients to go around. There's been graying of the space when it used to be the neurosurgeons did the delicate work, the decompressions, the orthos come in there, do the hard work, they're going to do the fusions. But now it's like they're both doing that. And then interventional spine guys, pain docs, have gotten a little more invasive, and then the surgeons have gotten less invasive. There've been endoscopy, the minimally invasive spine. It's been great to see, which is just better for the patient. We see the iPhone comes out and makes, all right, every other phone's got to get better. It's like that's what it's doing. New devices coming out is not, stepping on people's toes, but it's forcing everybody to be on their game and get better. And then ultimately patients win as long as, there's judicious use of all these devices. We say the right procedure for the right patient at the right time. You do, we've seen X-stop go away because people are using it inappropriately. It worked well in the right patient, and that's what, people have talked about. Like, oh, so just because we have a hammer, don't looking for nails everywhere. I was talking to a patient the other day that last time I counted, from my belly button down to my greater trochanter, below my hip, there's 92 different things I could do to treat pain now. 92, which is ridiculous to think of. Someone told me, I was asking a doc, and he's like, I think about probably 10 or 15. I'm like, count again. There are probably more than you think. Maybe not everybody could do the 92, but it's awesome what we can do now. And like I said, where the space goes is just, like I said, more minimally invasive. I like, with your Liberty and Minuteman, something goes in small and it opens up compared to other, when I do other devices, I have to go at 5-1 or remove an implant. I might go in posteriorly to do that. And a lot of them go in big, then go small. So therefore, my incision is bigger, 2 to 3 times bigger, more tissue trauma, more layers of closure, more time in the OR. So improved operative efficiency, miniaturizing, procedures and devices, and then with still maintaining efficacy and outcomes, but decreasing risk and mitigating those is where I see it going.
Okay, so you're adopting new therapies. These new devices are coming out. And I know you go to training and you learn about them yourself, but kind of a selfish question for me as our sales reps are listening to this and watching it. What role do they play in a new device coming into your practice? How do you partner with a rep to make that successful integration?
Yeah, absolutely. Great question. So the rep has to realize that they can be a valuable asset in my operative theater, in the operating room itself. I try and integrate them in, like I'll show them the imaging when I'm doing a pre-procedure planning, show them how to do that so they understand what I'm doing, why I'm doing it, where the implant's going, and show them all the calculations I do, because there's some physicians that don't do this, and I want them to help teach them so they can be a valuable asset for those physicians. But like little things as far as like for a Minuteman device, I'll look at the flexion extension x-rays. I'll tell my patient, flex forward as far as you need to feel better. And say it's the L4-5 segment you need to do. They have a little aesthesis there, a little facet fusion, a little lateral recess or neuroforaminal stenosis, causing that, L5 radicular pain. I'm like, all right, that's the level we need to treat. So I have them lean forward. I'll measure the interspinous process distance, say, hey, that's 10 millimeters. And I know I got to decorticate to prepare for fusion on the upper and lower spinous process. So I would guess I'm probably going to put a size 12 implant in there. So this is pre-planning I do. So I know if I get in there, I'm like, I'm only putting in an 8, that's probably not going to be enough. So the pre-planning that I do. In the operative room, I want them to be helpful. So I've talked to the reps for different procedures. I'm not loading the implant. I have a scrub tech doing that. But if they don't do that correctly, all right, that's your job to watch them. I want them to know every little detail about their product and everything bad that could go wrong to help mitigate that for me. And then for all the other doctors out there, it could be beneficial that they know that could help mitigate risk, And that's the trouble that interventional spine docs get into. People say, oh, they could get into trouble. They don't know how to handle all their problems. And there's no surgeon that could handle all their issues. We know even, neurosurgeons, ortho spine, they have to have the vascular guy, the general surgeon come in for access to get in there for the A-lifts. If there's any wound issues, sometimes you'll have to send them to plastics or wound care. So we all need other doctors, on our team in case anything bad happens. The difference I like to do is I would want to try and mitigate all those risks to make sure I prevent that. And having a good rep in the OR that knows every single thing about their product and knows the anatomy of that particular area very well has been helpful. And I think Spinal Simplicity has done a great job. I always try and show them when I'm looking at all the imaging, going over the advanced stuff, planning out SI joint fusion. I'm showing them all these angles I would do, whether it's a posterior approach or lateral approach. I like the study you guys did looking at measuring the average distance from the joint to the S1 foramen and saying, hey, we need 12 millimeters to open it up. So I always measure that distance and I look at where it's at so I know where I need to be. So I'm teaching all the reps all this fancy stuff I do. They learn that, and hopefully it's helpful for other physicians. But like I said, the biggest thing is them knowing the important parts of every step. Like a Minuteman, it's getting that guide wire in there. So making sure that they have the doctor do that perfect. Not tell me, oh, it's good, doc, it looks perfect. No, you know what, doc, that should be a little more anterior. Them having the brass to step up and say that to the doctor. Making sure that implant is loaded correctly, then making sure the wings, for example, in the right spot. So knowing when to speak up, knowing when not to speak up, knowing when not to fluff the doctor, whatever. But that's where they add the value. Understanding the imaging, understanding the anatomy, being a second set of eyes, like the SI joint, for example. It's a very complex joint. Some people don't understand it. It can get tricky in different views, and it throws you off, especially if you do like an inlet oblique view. It really confuses people. But understanding where you're at is helpful, and having a good rep that understands that. And you guys, like I said, have done a wonderful job of making sure the reps are rigorously trained and doing that. That's where it's very beneficial, especially for new physicians, I think.
So when we're talking about sales reps and the partnership they can bring to you, it's good advice because you're teaching, right? And you love to teach. And I know you're teaching on the weekends, but also teaching the rep imaging and in the OR. And so it's a good advice to them to be able to practice when no one's watching, so that when they come and partner with you, they can bring value to you. And so, but it doesn't just end with them. You're the one teaching them as well. And so I love that that's your mindset.
Yeah, no, I've always enjoyed teaching, and people talk to me early on in my career, and even to this day, they say, you should go into academics. And I'm like, no, I don't want to do that because I enjoy the doing too much. And then when you're in academic centers, it's more the residents and the fellows doing all that. So I still love doing it, but I really love teaching when doctors come and visit and watch and hang out all day. Like I've had some come for Minuteman, some come for SI joint fusion, some come for stimulator just to watch. And they're like, can I just hang out and watch the other stuff? And that makes me feel really good. It's fun. Like, all right, I feel like I'm adding benefit or value to them. And it's not very completely altruistic, but it's kind of like giving somebody the perfect Christmas gift is how I feel about teaching somebody. It's like you get so excited. You want them to open it at Christmas Eve. You don't even want to wait till Christmas Day because you feel like, oh, you were so excited that I'm giving them this gift. And I only see so many patients when I'm working. And I try and do my best for them and make my family proud, make everybody proud. But if I teach somebody something and that is of value and they could implement that in their practice, I have a very, very, very small hand in what they do going forward in their practicing. I have a small hand in them doing something great for those patients. So my reach should be a little more broader. So that's why I enjoy teaching. Like I said, I feel like it's the perfect gift and get all excited for that. But so the teaching I've loved. I've had a lot of great mentors over the years. Dr. Denise Lester with residency and fellowship, she told me early on, learn one new thing every day. If you do a 4-year residency, you're going to learn 1,400 things, Plus a fellowship year, you learn another 365 things. So I kind of try and stick to that to this day and try and learn a new thing every day, So if you ever don't know something, like when I was a med student, well, you go home and you learn about that to make sure you never don't know that. And this is kind of terrible, but I had an internal medicine doctor named Dr. Stephen Katzman when I was a med student, and he'd ask you questions. He was kind of like the human medical encyclopedia. He'd ask you these crazy internal medicine questions. And if you didn't know the answer, congratulations, you're worthless in a week. You would look away and you're like, whoa, I'm like, wow, that's terrible. I never wanted to hear that again. So I will jokingly say that in my OR now to this day. Like, ask somebody something, ask a rep that. Congratulations, you're worthless in a week. Jokingly, they usually heard the story though, but it's like, all right, well, I want to make sure I always know those answers. So let's read some more, study some more, learn all this. And then, like I said, pre-planning, that's one of my big things is preoperative mapping on CTs, and not just for SI joint fusion, but I do it for BV and ablation. As I said, I do it for Minuteman. There's all these little things you have. We're required to get imaging, utilize that imaging, know how to use it, and use it to your advantage so you could be efficient in the operating room and do what's best for the patient.
Yeah. No, I'm going to steal that. Learn one new thing every day. That's really good. A mentor told you that. Now you're telling other people that. That's awesome.
Thank you, Dr. Lester. For
that.
Yeah,
right? Yeah. Okay, one final thought. What should the pain community be optimistic about moving forward?
The ever-evolving competition in this space is, like I said, it's great. It's making everybody else get better, staying on their toes. So all these new procedures coming out, as I said, I'm a skeptic for most things, but you want to make sure it works. Prove to me that it works in the bench side. Show us that it works, in the studies, and then let's prove it with more studies going forward. But the G6 coming out seems pretty slick.
Yeah.
I like that I could already do with the G5 a 1-inch incision, to do basically an indirect decompression and effectively give somebody the relief they get with a laminectomy with or without a fusion with that minimal incision compared to a 2 or 3-inch incision when I come in posteriorly. And if you can miniaturize that even smaller to where I get a 1/2-inch incision, that's pretty slick for patients. They're winning with that. So the ever evolving nature, and you guys have some fun engineers. A lot of people are smarter than me. It's cool to see what they come up with.
I think that's kind of become our brand, is just innovation and pushing the space forward. And so it's not only exciting for you, but it's exciting for us too. It is a lot of fun. So Dr. Bovinet, this has been a blast. Thank you for being on with us today. Thanks for coming to Kansas City. Hopefully we'll get some good barbecue here this afternoon. You enjoy your time here in Kansas City. Thanks for coming on.
Thanks for having me.
Yeah, good to see you.
This podcast has been financially supported by Spinal Simplicity. The content is for informational purposes only and should not be relied upon as medical advice. The views, opinions, and information provided by participants are their own and may not reflect those of Spinal Simplicity. Healthcare professionals must exercise independent medical judgment, and patients should always consult with a qualified healthcare professional regarding medical decisions. Finally, the healthcare industry is constantly changing, and neither Spinal Simplicity nor the participants can guarantee the accuracy, completeness, or timeliness of the information provided in this podcast.